Hello, everyone, and welcome to the Unquiet Mind podcast. I am your host, Dawn Morgan, and I'm really, really happy to be here for another episode and another, topic in our trauma series. I'm here, and I welcome you, Achara Tarfa. She is a certified recovery coach. Trauma. See, I get it. That's my MS brain. Please correct me, and she will introduce herself. But I feel horrible for screwing it up from the beginning. But if you watch our other episode, you'll see we kind of touched a little bit on trauma. And today we're going to be talking about something that is so new to me, the polyvagal theory. So I'm excited to discuss it and dive in. And welcome.
Thank you. Yeah, no worries. It's a sort of a mouthful and not necessarily a new thing, because it's been around, for many years, at least the field of trauma and trauma recovery. But for mainstream, I think it's quite new. So yeah, I'm a certified trauma recovery coach, and I am at the supervisor level of that certification with the International Association of Trauma Recovery Coaches. So yeah, that's a lot. It's a mouthful.
It's definitely a mouthful for my MS brain. It is today. But you all are definitely needed. There have been so many things in the world in recent, I would say, years that have affected all of us globally. Speaking of what's global is the pandemic. So a lot of people, I'm sure, need counseling and guidance and just a deeper understanding. So my hat goes off to you all.
Yeah, we've in what we do, right? So in trauma recovery coaching, we are mental health professionals that use coaching as our modality to provide attunement and co-regulation experiences for our clients. So oftentimes we don't feel safe within ourselves, we don't feel safe in relationship, and we don't feel safe in the world around us. And as a trauma recovery coach, safety, like Dr. Levine says, safety is the treatment. And so we provide safe spaces and hold these safe spaces for people in all of their parts as they are recovering from trauma.
I'm glad that you said the word recovering, because I always thought, before we dive into the topic, but I always wondered, is there a recovery? Is there, because I've experienced trauma, and I wonder, does this trauma guide a person's life? And is there recovery? Well, obviously there is, because there wouldn't be you and others like you, but I never thought that there would be recovery from that.
Yeah, well, recovery is a strengths-based, empowering modality, right? And so our coaching, through the association, the way that our certification, our programs are set up, it's the constraint release model. So we are in recovery, right? It's because of trauma, and trauma is not necessarily cognitive, right? It's a wound that we carry that's stored in the body. And so we can be in our day-to-day lives and then, sort of have a trigger, or in IFS terms, they'll say trailhead, and it'll cause us to, there'll be an event, and then we'll have this autonomic response to that event. And then we sort of give meaning, right, to what has then occurred. So then our beliefs and whatever our experiences, our confirming experiences from our past have happened,
right,
that will, go. So recovery is possible. Yeah, because it's possible. It happens on a daily basis.
Right. And that's what you're doing. You're coaching someone on how to manage and how to deal with those triggers, for example, like you said, because there are always going to be something that comes up throughout.
Yeah, and so it's because of neuroplasticity, right? We have new neural pathways that can be created. We have our nervous system. So, Deb Dana says we're going to talk about polyvagal theory, and she is the really, like, I will say premier. She may go, oh, for real. Like she is the first, like foremost person in my mind that has applied the polyvagal theory to trauma. And she says, with a regulated nervous system, symptoms reduce or resolve. And so that's sort of what you're learning, you're titrating into, right? Like not necessarily, we're not always going to be in a regulated nervous system. It's really how do we learn to navigate through our nervous system as we understand it, because we all have an autonomic nervous system. And with polyvagal theory, it talks about it as far as it breaks it down into different parts.
It's so interesting. It's so fascinating to me, especially being a person who has a neurological disease. You know, how does all of that, I'm working on trying to find my answers. How does all of this play into how I am coping with my everyday life and my everyday trauma of knowing that this neurological disease or challenge has affected me in every way? So that's why when we started talking about polyvagal, I was like, oh my gosh, this is so interesting. But I'm going to read what I just kind of researched. I am literally just touching the surface of this. And because it's so layered, and we can probably go on and on. But I wanted to introduce it to everyone because it's new to me, and I'm sure it's new to a lot of people. So I'll read to you what I found, and then you can kind of take it from there and talk about it in a deeper, explanation of what it is. So the polyvagal theory. According to the polyvagal theory, it shifts like you said, the autonomic nervous system, and it produces three elementary states: rest and digest, social and safe, fight or flight, mobilization, or shutdown, immobilization. There's a little bit more, but it's so heavy. I want to just like break that up. So can you kind of explain that?
Yeah.
In a nutshell.
Sure. Yeah. So, and I love this because one of the things about our brains, our brains do everything in service of survival, right? And so our brain's job is to make sense of what is happening in the body, right? So I love this because I feel that energy of we want to make sense of what's happening in our bodies. So, so you spoke on the three parts, right? So we have the ventral vagal, right? Which they refer to the ventral vagal. So part of the autonomic nervous system, there's a parasympathetic nervous system. That's part of that. It's called ventral vagal. Then we have the sympathetic nervous system, which is the system of mobilization, right? Yeah. The ventral vagal, what I just mentioned, is that system of safety and connection piece that you just talked about. Okay. And then we have the parasympathetic nervous system, which is that dorsal vagal or dorsal vagus. So that's the system of immobilization. Okay. So again, the brain's job is to make sense of what's happening in our body, and it's always trying to keep us alive. So based on our autonomic nervous system and events that happened, we have these, according to polyvagal theory, right? We have these three sort of responses, and you have if I feel good, if my neuroception, which is also part of polyvagal theory, it's sort of cues of safety and cues of danger. So if I'm picking up cues of safety from you based on your eyes, your smile, your disposition, then I'm going to feel that parasympathetic nervous system, ventral vagus sort of combination where I feel safe and connected to you. There's opportunities for health and growth and restoration and just like, this feels good sort of thing. And I want to stay connected, right? If there's cues of safety, if there are cues of danger, okay, our autonomic nervous system takes us into a response of mobilization. And that is that fight or flight response, right? So we have to protect ourselves through action. So I've either got to put my dukes up and fight off the predator or fight off this oppression, or if I can't, I want to flee and get away as quickly as possible, right? Then what begins to happen is if I can't either fight or flee. If I can't move, if there's no mobilization and protection through action, then my body goes into a response of I need to protect through disappearing. And it's a system of immobilization. So there's a hyper freeze, like I'm just, that's that deer in headlights where there's a lot of energy, but you're just frozen. Or there's that completely like depressed, disassociated, like numbness, like just that rest digest to the extreme, right?
Okay.
And that's when you sort of think of somebody kind of trapped in a box, you have no way out, then the way to get out is to disappear, right? And have immobilization.
Okay. That makes so much sense. And I know I've asked you this before, but I want to ask again. In terms of receiving a diagnosis, cancer, lupus, fibromyalgia, MS, um, any a rare disease, how does that trauma? Well, I have to think of the right question. How does that? I don't know the right words here. How does that play into the polyvagal, like what you just described? Because nobody's like hurting you, like physically, another human being isn't hurting you, but something that is out of your control. So is that what trauma is? Something out of your control that's hurting you? Is
Yeah.
that?
So if you want to think in terms of a physical hurt, right? So instead of that, instead of like touch, let's think of it in terms of, let's say, I love using inflammation,
Okay.
right?
Mhm.
So inflammation, right? Chronic inflammation is something that is harming, is hurtful to our system, to our body.
Right.
Yes.
Yes.
Right. So when we have stress and we stay in this activated, stressed state,
Okay.
right, where we've got the cortisol and the adrenaline and all of that from our so when we have that autonomic when we have that response, right, without thinking, our body knows that HPA, right, that's the hypothalamus, oh my gosh, why am I drawing a blank? I'm drawing a blank now, right? Our adrenal glands on our kidneys,
Uh-huh.
yeah, and our pituitary, so that HP axis, right? So it sends that signal there, and we have this sort of chemical, these rush of these chemicals.
Yes.
It's just our bodies are electrical, right? And our hearts are electromagnetic.
Yes.
So when we have this inflammation in our bodies, as a result of a stressed response, and it's chronic over time, right? Then that can lead to physical manifestations of maybe that rest and digest part we talked about, right? So
Yes.
IBS or constipation or digestive issues, which you see often.
Yes.
We have that sort of fight flight response. People feel that because this vagus nerve, right? We also didn't mention that polyvagal theory comes from talking about the vagus nerve. That vagus nerve is cranial nerve 10, and it connects all the way from the top. So if you think about from here, your neck,
Yes.
and then you take your hand and you sort of kind of meet in the center, that's our sympathetic right here.
Okay. Uh-huh.
And then we have our parasympathetic, which is that rest and digest part. So we feel like maybe rapid heartbeats, maybe people experience panic attacks, maybe they experience anxiety, like they're maybe people have an arrested breath, right? So they maybe have respiratory problems. And so, yeah, I have our founder of the association. She's been really doing a lot of work and sort of conversation around the area of depression. What if depression is really a nervous system response in the dorsal vagal state? What if it's really that?
Oh my God, yes, I can completely see that. And I can understand that connection.
Yeah, because the symptoms, they look exactly the same. So what if we treated it and we treated the safety part in someone's nervous system? How would depression then look if we looked at it from a co-regulation, attunement, neuroception perspective?
And when you say co-regulation, can you just kind of describe that? Because some people aren't familiar with a lot of the vocabulary in this.
Yeah. So co-regulation is basically where I am picking up your cues of safety and or danger, right? And understanding, okay, you are just based off of your cues, right? And people often use like intuition and things like that, right? But it's my nervous system meeting your nervous system.
Okay.
And us co-regulating in our nervous system. So right before this conversation, I had a call with someone who I work with, and I had agreed to set her up for success before I had left. She had to do something for us. There's something that we do together. And I had made a choice because I thought I had time the next day to do it. And the next morning when I thought I would have had time to do it, something else happened in my life, and I was unable to do my part and set her up for success. So that left her sort of kind of squirreling, and she got it done, because she's, capacity is not about capacity, right? It's about supporting someone. And so there, in other spaces, right, non-trauma spaces, unfortunately, when you have that, that could have led to a pretty massive rupture, right? But I went ahead and spoke to her and named it, and she began to cry, because that was my intentionality of co-regulating with her. So she began to cry because she had never had someone own their mistake. She's just worked in her life and just picked up the ball and just did it and carried on, and really sort of not met her own needs for the sake of the greater good, which is admirable, right? These are admirable, rewarded qualities. But I told her, I said, when it comes to me and you, I want you to name your need. And there was a part of her that was like, oh, and it wasn't shame. It was just, this is a new emotion. I've never had anybody say this to me, holding this space. And so as she began to cry, I held that space for her, and we co-regulated, right? So that's the best way to sort of explain. We were co-regulating.
I understand. Okay. Wow. Oh my gosh, you are just like so fantastic. I love it. Oh.
And that's the great thing about polyvagal and understanding parts and nervous system and all of that, because I could have, not held the container of her tears, right? And I could have taken that as offense, or what am I going to do, or God, and that none of that, because of co-regulation, right? And the safe space, we were able to hold space for each other in safety.
It's so important that you're saying this, and I want people to hear this, because when you again have an illness, the inflammation, whatever disease it attaches itself name to, doctors need to hear that, because you need to co-regulate with a doctor. They need to understand. You need to be able to get your needs met. I don't feel well.
Can I share with you something? I just had a conversation with a prosthetic surgeon who works in the vascular spaces, right? And I just want to name, my daughter just woke up, so if she comes over, she might be a little loud. She's like, that's okay, pattering around. Okay, so and I just met her at this play date place, right, for my daughter, and we were sitting there. You just get to talking to people and so forth, and what do you do? And so she told me what she did. Oh, I'm in prosthetics. I said, oh, what do you see most in your clients? She was like, diabetes. That she sees a lot of patients that are diabetic. Right. So she works in prosthetics. So they are now at the point where they are having to have something amputated. Okay.
Yes.
So we're talking about this, solution of amputation to help with this dis-ease, right, of diabetes. So we're talking, and I say, so what is your, some of your biggest challenges with it, so forth? And she was like, well, I hear a lot, and she thought of her own mother. Just, this non-compliance, she said, I just see a lot of non-compliance. They're told, eat well, do this, do that. And they're just non-compliant, I just don't know, I think about the stubbornness of my own mother who's diabetic and non-compliant. And I'm just listening to her, right? And I'm just there, and, she doesn't fully understand what I do yet. So I said, oh yeah, so you're on this end of the spectrum. And I'm on this other end. I'm more of on the preventative care side, so that they don't get to the point of where you're amped. She's like, because there's so many of them that are just like, yeah, just cut it off. Just cut it off. And I had to let that land for me as a trauma recovery coach, that we live in a world now where people are willing to just have their own limbs amputated. Instead, like, how far have we gotten into a society that a person feels like what's best for them is to amputate because no one listened to them or took the time to figure out maybe why they're comfort eating, right? Maybe why they're stressed out. What is it? And so now they're at the point where they'll choose amputation. And then the doctor just sees it as non-compliance. And this is our last resort. And this is what we have to do. So I told her, to wrap the story up, I said, I'm going to invite you to understand the why behind the what. I'm going to invite you see it as non-compliance. And I said, and I hear you. And maybe if I had your mindset, I would see that as well. I said, but I don't. I see it as this person doesn't feel safe. So they're gravitating towards behaviors that make them feel safe. And it's a day-to-day thing. So yeah, maybe you see it as non-compliance, but I have curiosity around, well, why are you eating that donut and that thing? Like, what's going on? It makes you feel safe? Okay, makes you feel safe. Why do you think you need to feel safe right now? What is it that you need comfort for? What's going on? What do you think's going on? And just sort of go from that angle. And she was like, she's been doing this for over 20 years. She said, I've never thought about it like that. And then she asked for my information.
Of course.
And she said, I've never thought about it like that before. Huh.
My eyes are watery because you've said two words, non-compliance and don't feel safe, or a few words. When you have a disease or an illness, I can relate. I was a non-compliant patient for a number of years. And I was told by a neurologist, you're non-compliant, and it was turned into a combative situation. And I felt bad about myself. I'm like, I'm non-compliant, like I was being chastised.
Yeah.
Instead of feeling that this is a safe space. My neurologist now is probably the only person on this planet, she doesn't know this, that I feel completely 100% safe with. I feel like I can turn my life over to her, and she would hold it in her hands and care for it. And that's why this type of conversation with the prosthetic doctor and what you are presenting to her, and hopefully others, maybe she'll go and tell someone else, her colleagues, it's so important, because that plays such a role in our nervous system and in that safety and in all of the fight or flight or immobilization, because patients will come in and they'll just shut down and they don't want to talk. Because they don't know.
Especially if they're being shamed and being told that they're non-compliant. You have people who are coming in, and people who are maybe even rule followers, right? Or you tell me I'm non-compliant, I'm gonna have two responses. I'm gonna have a part that wants to flip you off, right? And not do what you're saying just because you just shamed me with that label. Or I'm gonna have a part that feels the child response, or the part of me that's very young that will want to run away and hide, and you can't, and be immobilized. And so there's not a place of safety and connectedness. Those will be the two responses likely that will come out. Now, because of the practices of internal family systems, mindful self-compassion, and our trauma recovery modality, I don't have those responses, right? I don't, because I'm able to understand that if someone were to say that to me, right, that's more about them and what they've been trained on and so forth. And they obviously haven't been trained on trauma or been led through how important co-regulation and attunement is for people. I have a cancer survivor as a we're talking medical and patient, they're not as a client.
Right.
And she said, I just got back from seeing my doctor, and she's noticed a significant difference in me. And she asked me what I've been doing, and I told her about you. And she was blown away because my blood work is much better, or there's all these things are much better. And she was like, she wanted your information to talk to you. And I said, oh, okay. I have a friend who is a nutritionist, and all day, every day, she educates, right? As against, right, non-compliance, as a deterrent from non-compliance, to get people to not be non-compliant. She's the person that comes in and educates people on what they should do, eat this and do that and do this. When it comes to the trauma piece, she's been like, I don't want to handle those emotions and all that stuff. So these people are literally in the system. I don't know, but my own mother is diabetic. And she's never talked to me about somebody asking her, hey, what is it that you're not feeling safe about or whatnot? That's not happened, right? But she'll be trained on what to eat and what not to do and da.
Yep.
But we're not getting to the trauma of why those behaviors are there.
Well, and I think it's fear too. Like fear plays a huge role in, I'm not safe, so I'm fearful. I want to hide. And that's all I wanted to do. I consciously wanted to be non-compliant because I didn't trust, number one. And it wasn't that I didn't trust the physicians and all of that. I just didn't trust that they understood me. And so that kind of led to the non-compliance and the shutting down and the rest and digest that we were saying with the polyvagal. It's something that doctors really need to understand, but it leads to our healthcare system. Do they have time to deal with that?
Do they have time? I don't know. I'm not a doctor, so I don't know what they're trained on. And the doctors that I do know, right, wow, they are so stressed out and under the gun. And maybe they have their own counselors or therapists that they go to. And I know through our association, we have lots of psychotherapists and psychologists and people coming through and going, I've never understood or been trained on trauma this way, where our program is experiential, right? So they're actually dealing with their own childhood emotional neglect or their own trauma or their own as their process. And that then helps with that attunement piece and really being able to be vulnerable and maybe not even necessarily with words, but you can sense that, our hearts have an electromagnetic charge to them. And so that can be felt when I'm in the room with a physician. That really it can be felt without words. That's our neuroception piece of the polyvagal theory.
Oh, this is just so good. This is going to continue. We have to have another conversation about this because I'm looking at the time and I have to get my son. But I before we kind of like end this and wrap it up, I wanted to read the second part, what I found about polyvagal.
Yeah. And
I just wanted you to share your thoughts and your expertise on the whole, I don't know, this concept. Or it's not even a concept, the theory.
Yeah.
It says that the polyvagal theory teaches us that post-traumatic stress symptoms are biologically based and somatically experienced. Once
Mhm.
you understand the physiology behind CPTSD, we can talk about that. I really want to talk to you about that too, but that's a whole different arm.
Mhm.
The physiology behind CPTSD symptoms, you realize why you cannot simply think your way out of trauma
Right.
reactions. Can you
That's
just
right.
talk about that?
Yeah, because we don't, when we see a car coming or we see something happen suddenly, we don't think, there is a car coming, I'm going to move out of the way. There is no, we don't cognitively process that, right? There's no thinking part of that. We just jump, we just move. I live in Florida. If I see a snake going by, my cognitive brain doesn't know that that's a snake, right? There's an autonomic nervous system response that jumps back. And then I'll go, what the heck was that? Oh, that was a snake.
Right.
And so then the cognitive part kicks in. So when it comes to trauma, we can't think our way out of trauma. We can't, we just can't. It's not, it doesn't, it's not stored there, right? It's stored in our body and our nervous system. And so when it talks about it being a biological, right? It's
Right.
biological, that's speaking to the actual biology, right, of our nervous system, of that cranial nerve 10, and it connecting to our all the way. I mean, if you look at a diagram, maybe there you can put a link in your comments of a diagram of where this nerve touches everywhere in our body,
Yes.
down all the way to our, our gut, our stomach, our gut, all of that, our intestines. So that's that biological piece, right? And then the somatic experiencing of it, so the body piece,
Okay.
right?
So somatic is the body piece, right?
Yeah, somatic meaning body, right?
Mhm.
So that is our biology and how we're created. And
Yes.
then there's a body experiencing piece.
Ah, yes. Okay.
So which, yeah, either immobilizes us
Mm.
or mobilizes us or mobilizes us,
Right.
right?
Like seeing a snake would either immobilize you or
Yeah.
cause you to run.
That's right.
Right.
That's right. Unless, or if you're somebody who doesn't mind snakes and actually feels connected, you're going to feel a sense of safety and wanting to be with them. So, like everybody is, it's just how our nervous system is wired based on, confirming experiences that we've had. So if I've had an experience that snakes aren't dangerous, then it's not going to bother me. Right.
So when you experience trauma, does your nervous system automatically want to run, or does, like, what does it do? I guess everybody's different,
Everybody is different. Some people freeze, right? You have that fight flight response. And then again, if you cannot fight or flight, then you will have that dorsal immobilization.
That makes sense. Okay. And when you say dorsal, that's
That's
the
that rest digest sort
oh,
of like, and when I say that, I want to also emphasize that there's a hypo freeze, right?
mhm.
So there's just this protection to disappear, and there's a hyper freeze
Okay.
where we're speaking of tension and energy in the body. So you're going to feel a numbness in the hypo freeze of immobilization, protection to disappear, or you're going to feel a hyper freeze, which is a tension in the body, but still immobilized.
Okay. When I was diagnosed, I immobilized. I went completely into denial for about 9 years.
Mm-hmm. Yeah. Yeah.
Is that abnormal? I don't
No. So
know.
the denial was the denial. So when you have denial, right, we have a piece of it that is a disassociative denial, meaning there's just a numbness and there's just like apathy and like no feeling towards it and no feeling at all, like very numb. So that could be a hypofreeze response to in denial. But in denial as well, there's an anger component possibly as well that's there. And so was it a hyper freeze? Were you just mad and just, immobilized in the hyper freeze? Which type of denial was it?
You know, I guess, quickly answering, I think it was a hypo. I wasn't angry.
Yeah.
Because I
Yeah.
thought that I literally thought I was immortal and I could fight through it and I could cure myself and I don't need this, which, played into the non-compliance, but it really was me being fearful.
Mhm.
And, eventually the hyper came along, because I went through those,
Yeah.
I guess the stages of grief play into this whole thing too.
Yes. Yes, absolutely. So I really, before we have to wrap, I really want people to understand that, especially when, so there's Deb Dana, I mentioned her earlier, she has this personal profile map that she does in her work, and it's beautiful work. So she, you sort of envision the nervous system like a ladder, and at the bottom of it is this immobilized collapse state of dorsal vagal, right? And then you go, the next rung is, a few rungs are the fight or flight state, where there's the sympathetic nervous system mobilized. And then you get to the top, which is ventral vagal safe connected, okay? People need to understand that in order to move out of this, hypo, sort of collapsed dorsal vagal, sort of response, you kind of use some of that energy from the sympathetic, from the fight or flight, to sort of move you out from immobilized state to a mobilized state, right?
Right.
So you had just described, you were just in this denial. And then there came this mobilized state of, there was some sort of anger there, right? That you sort of came into, right? And then you went into this now where you're at, of this sort of safety connected. So you used, as you're nervous, as you were processing this diagnosis, you had this immobilized response. Then you sort of came into this awareness of this anger piece, which then moved you into mobilization, which then now, as you worked with that piece, I'm sure, which grief can come and it can knock you back down into this immobilized state too. But then you've moved into now this acceptance and advocacy in this ventral vagal space that you're in now. And when we enter that space, we have more capacity to deal with the grief and to process the grief
Mhm.
within our own selves, feeling safe within ourselves, to our parts are okay with that, with someone else, maybe with a coach or a therapist or your doctor, like you said. And then as you're doing, having agency in the world around you to really advocate and talk about this. So you just literally, your process, you just sort of described your own autonomic nervous system response and how you came out of that. You just didn't know it was polyvagal theory.
No, and that's where I got the information from Deb Dana online. So I'll have
Yeah.
to definitely put that information in the show notes. Yeah, I was on this ladder, I suppose. And I do feel that there has been a stabilization, but like you said, you do kind of go back. I have moments where I just freeze. And I'm
Yes,
sure a lot
of
of people
course.
go through that. I don't want to do anything. I want to isolate. I want to hibernate.
Mhm.
Um, I don't feel like a victim, and I'm not like, oh, woe is me. It's all me. I
Yeah.
don't want to talk to anyone.
Yeah.
So,
Yeah. And so when it comes to those types of times, right, for anyone, it's important to like sort of notice and then name what's going on. And part of her work also is sort of mapping your nervous system, but then also sort of going, okay, what keeps me in this state of ventral vagal? Or then what knocks me out of it? And then when I'm in dorsal, what keeps me here? What moves me out of this? So understanding how to resource yourself, understanding when you are in those states, what those states are to your system, understanding what they are, so being able to name them and identify them, then understanding when you're out of those states and what then moves you in back into safety.
I love this. Oh my gosh. I love this.
So it's this has happened. Okay, let's note it's a name. Okay, what state am I in? Okay, I'm here, and then sort of move out. So there is a cognitive piece to it once you sort of map it out, and then you sort of, there's this mind body integration piece, the somatic piece that does touch the cognitive, and then you're able to move. So some people, some clients I have, when they're immobilized, they really uh, like one client, I asked him, he felt really sort of collapsed, and but it was a situation at work, and we had already mapped him earlier, and one of the things that puts him to fight or flight sympathetic was advocacy, like for his his team, like his work for his team, like he's really goes to bat for his team. Well, he felt like he had, a sort of a dorsal response and was really sort of depressed. And so I asked him if he could sort of envision, like picturing sort of maybe borrowing some of that energy or accessing some of that energy of that fight or flight. Like, well, but you're doing this for your team though. Like he was depressed that what he was trying to do wasn't working. And it was sort of about him. And I kind of touched on with him about, oh, well, you remember you had said, I'm just curious about, you had said about your team. And then he sort of, I could see in his eyes, like a little bit of access to that mobilized energy that got him out of that immobilized response.
Right.
And then it was like, oh yeah. And he's like, wait, so being upset for my team is okay? And I was like, yeah, absolutely. Absolutely. According for you, that's what helps you feel safe, right? And then feeling the connectedness and camaraderie. So that led to a whole, like, now they have team meetings about what people have problems with, and then he's able to understand and be a lead. I mean, this is this whole thing that I guess led to that, just because he was able to identify his system, was able to identify what helped him move out of it. Right. And
like giving yourself permission to feel those feelings, to understand and to not understand, and be okay with not understanding.
And it can happen, just here cognitively, or it could be like, I need to take a walk, or I need to do whatever, or I need to maybe meet with my team and really sort of dissect this, whatever brings you into that mobilized energy again safely, and then put you back into the ventral vagal state, because you're going to have that, right? You said that the world is triggering. So how do we then navigate through our nervous system?
Right. Oh gosh. Will you come back and can we talk about this some more? Can we talk about another aspect of trauma and a little bit more of the polyvagal? I really want to dive in a little bit more, but before we wrap things up, and well, you didn't even say yes. I'm forcing you. But before we go, I want you to talk about what you're working on and how can people find you, and how can they work with you?
Yeah. Well, how did you find me? No, I'm just kidding.
Yeah. Well, I was just researching trauma, and I said, I need to talk to someone. I want to understand this, because I wanted to piece together being diagnosed with something and trauma. Is it that? And I did my reading and found you on Instagram.
There we are.
Yeah.
Yeah. So Instagram's a big place, right? So Achara Tarfa, at Achara Tarfa, ACHARA TARFA. That's my Instagram handle. So I talk a lot about my own journey in trauma recovery, and the different resources I do, and my own system as far as how I've mapped my own nervous system. And I talk about my parts. So, and a lot of the content is around, my adverse childhood experience. So if the person doesn't know about their ACE score, I would encourage them to go to acestoohigh.com and learn a little bit more about their ACE score. And not to say that a number diagnoses you, but it definitely helps. At least it helped me with understanding myself a little bit more.
Yeah.
And so, the content is about, it could be anything from, I'm a domestic violence survivor, so that narcissistic abuse survivor, childhood emotional neglect, lots of things there. So they can find me on Instagram, or they can find me with the International Association of Trauma Recovery Coaches. I can send you the link. I have a course that's coming out in January. That's 10 weeks, and people can become a certified trauma recovery specialist. So that's exciting. That's coming up. They can find me. I'm often a panelist on the Trauma Research Foundation's book club. I'm also a panelist there often. Where else can they find me? Yeah, just around.
In the world. Yeah.
Oh, and a big thing is PATH. So I'm a board member with PATH, and PATH is a pathway to addiction and trauma healing. And I'll also give you that link there too that you can post. But it really is a place, it's an online support community where people can talk about not just their addictions and the recovery, but also trauma too, because I know in a lot of 12-step spaces that trauma is not really talked about as much.
Yes.
And so what we do is we bring those two spaces together in health containers of safety. And we have lots of meetings. We have people at the global majority meeting. We have a queer meeting coming up. We have women's only, men's only. So that's a big part of my work too, is path and advocating for people that way too.
Yes, I'm going to add all of these things in the show notes, and I look forward to speaking with you again. I've learned so much, and I'm continuing to learn, and I absolutely love dissecting all these pieces of the puzzle of the nervous system, and these theories, and just what makes us tick, pretty much.
What makes us tick? Yeah. And the great thing about polyvagal theory, though, also is there's been, since it's come out, right, there's been Stephen Ford just developed it in 1970s and 80s, presented to the clinical world in 1990s. And then since that time, there's been hundreds of peer-reviewed, like just papers, and there's been stories and reference the theory, and people working in the field that have used it. I myself in my own practice have seen it transform a person and in their healing process. So it's been around a long time, but it is a theory. I hate that the word theory is attached to it, because I want it to be very Mandalorian. This is for my Star Wars audience fans, because I'm a Star Wars fan. But I want it to be the polyvagal theory way, like this is the way. And because I really do think that if we introduced more psychoeducation about trauma to the public, and how it stays in the body, and polyvagal theory, right? We would have and complex PTSD, we would have a world that a system of healthcare that is really getting at the root of a lot of what people have now.
Absolutely. Thank you. Thank you. Thank you. I'm forever grateful. And like I said, I look forward to.
Yeah, I'd love to come back. I love hanging out with you, Dawn.
Thank you. I just feel so full. I feel like I've taken about 4 college courses.
Yeah. And I'm so happy you do what you do. I want to validate, right, and attune with what you do. And I'm sure for a really long time, it was just like, no, and to have to be told that you're not compliant for so long, that couldn't have been fun. So I'm really happy you found someone who you feel the most safe with, because not everybody has that, and that's really awesome.
Oh yeah. And that's why I'm in this space. Patient advocacy is my passion. It's my life now. So yeah, I love all patients, all of us. None of us are immune to any of this.
Yeah.
Or strife and illness, and you're not immortal.
Mm-hmm. Yeah.
Thank you. And thank you for coming on to the Unquiet Mind podcast.
Thanks so much.